welcome everybody to part 2 of my interview series with Jessica Funk. I've just named you the Awake Dentist. Okay, so I hope that works for you. So in our first talk, I mostly wanted to get your backstory, I suppose. You know, who are you? Where did you come from? What was your waking up moment or series of moments? And today I want to delve into a couple of areas. One that I know is just a huge interest of yours, which we touched on briefly toward the end of our first talk, and that is airways. And then there's quite a few questions that my regular Substack readers asked, and I'd like to get your input on them. So, all right, do you want to take it away? What on earth is this thing called an airway? What does it do, and what's the problem?
Just a minor thing that brings oxygen into the body for our cells to use.
No biggie.
No big deal. And I would say what's funny, because I referenced this in our last talk, was, I've been in dentistry for a while because I worked with my dad as a child, and he was making these snore guards back in the 80s, which is a mandibular advancement device, something that pulls the lower jaw forward to unblock the airway that would keep people from snoring. And this is before we had the buzzword of obstructive sleep apnea. So I was familiar with these appliances, and he made quite a. Go ahead.
Did he ever talk to you about why he was making those? Like, what the problems were that he was seeing in his dental patients that he wanted to help fix?
Other than just to pull the tongue away to keep patients from snoring. And again, I was a teenager at the time, so if he gave me a broader picture of what it was, I may not have been able to identify all the points that I would now. And I would say they were very popular in that they were effective for both the patient as well as the partner, who didn't have to hear the snoring sounds. And when I was in dental school, if we had any training on that, it was extremely minimal. And only I would say in the last 10 years have I garnered an interest in it. And then in the last 3 years where I've really had a passion for it, because I think one of my frustrations through COVID was, as a dentist, I was aware of what was going on, but I felt sort of helpless to have the same impact that you or other healthcare providers who are directly able to impact someone's overall health.
In other words, people are just coming to you for their teeth,
right? And
they don't see you as being part of their, I suppose, broader. They don't see that you're part of the healthcare team, but your position in that team is very circumscribed by the fact that Jessica's a dentist, right? Yeah.
Right. And how as a dentist, why are you talking to me about vitamin D and C and zinc when my doctor's just telling me go to take a vaccine? I would certainly I would be lower man on the totem pole. And the airway, because as dentists, when we do, as dentists, we should do what's called a soft tissue exam, which is an oral cancer screening. And in that, you're looking at the airway. And as you're, evaluating the airway for potential concern, you're also looking at, how well can you view the airway? And in a lot of cases, you can't. The tongue is so large, there's enlarged tonsils, elongated uvula, that you wonder how the patient even can breathe, because the airway seems to be so constricted. And so as a dentist, it just became a passion to help people sleep better. And plus, I'm a big believer in sleep. I think fundamental to our overall health is our ability to get a good night's rest. There's so many elements to that beyond, like what we were just talking about before we started to record, eating early, not eating before you go to bed, at how it impacts your sleep. So it kind of blended two passions of mine that, as far as wellness is concerned, and that is sleep and airway. And
so given that, sorry to interrupt, but given that all dentists are by definition looking into people's mouths all day, are they seeing what you're seeing in terms of these airways that are almost completely obstructed by something or other?
I think that it is becoming something that is more recognized, that my generation, hopefully the generations coming behind me, are having more of this education in school because obstructive sleep apnea is, I think we touched on this a little bit last time, but I think about in our country, about 30% of the population may have some form of obstructive sleep apnea.
Mm-hmm.
And the role of the dentist in making the mandibular advancement device or mandibular positioning device has kind of pushed us into part of the treatment. Therefore, I hope that dental schools are covering this topic. And it seems to be when I'm doing my learning on this, that there seems to be a lot of interest, which is great. I'm grateful for that.
So this was not a topic that you were taught at dental school, though. Oh, that's so interesting. Right, so you learned this from your dad. You didn't learn it in your formal instruction, and now you can see that with the, I suppose you're doing some kind of continuing professional education.
Correct.
As a dentist, and so this is being emphasized. Okay, so that's a good thing anyway.
And where I sort of started going into the education on this was my interest in bruxism, which is the grinding or clenching of teeth, a parafunctional habit, a habit that people have that can create a lot of stress and pain, headaches, neck issues, and those two can often run parallel. So as I was training to learn more on that topic, then the sleep kind of the two kind of melded together.
Mm-hmm. Okay. Yeah, interesting. So sorry, I interrupted you. Pick up the story then. So you're delving more into the airway, and this is
And as I was getting more into this, one of the frustrations I've had, and I'm sure you've had this as a provider, is that I would talk to patients about their airway. I would recognize the fact that they had an enlarged tongue, enlarged tonsils, elongated uvula. One of the clinical signs that we would see as a dentist with a dentition is a worn anterior dentition. That means the teeth in the front have some type of wear pattern that would not come from normal function. And so then my role would be, well, I would like for you to go see your physician and have a sleep test done. And I can tell you, I can probably count on one hand, after making hundreds of recommendations to go have a sleep test done, how many patients actually followed through with that request. And main reasons, the pushback I got from my patients was, I don't want to go sleep in a clinic somewhere. I don't want to be, hooked up to electrodes. And the classic, and I don't know how it is in your country, but the classic is my insurance won't pay for it. Mm-hmm. And so one of the things that I implemented probably 7 years or so ago is an at-home sleep test that patients can take and do in the comfort of their own home. And I made it a nominal fee of $50 to take home. And I call it my public service to our patients, in that I wanted to remove the two main hurdles that I had. After they test, what they do with that information is on them. And I work with a sleep physician if we need to get for professional reading of the report. But I make when I talk with patients about their sleep study, I take the opposite approach of what I see medicine doing. And I don't know how it is in your country, but it's patients of mine who have gone and had sleep tests done elsewhere. If they fall in a category of mild, even sometimes moderate, they're just told, you're not bad enough for a CPAP. No treatment's necessary.
Yes.
And and that just, that makes me so upset for those patients.
It is very similar here. If you get a referral for a laboratory sleep test from a specialist, it'll largely be subsidized by Medicare. We do have pharmacies that actually hire out the in-home sleep test that you mentioned for a very low fee. It's affordable for most people. But yeah, just like you say, if people are diagnosed with sort of mild to moderate, they might be given a few sort of general tips like, well, you're overweight. If you lost some weight, then your sleep apnea would get better. But there's no follow-up on that, and there's no coaching, and there's no referral to effective weight loss programs or anything like that. It's just, well, you have sleep apnea because you're overweight, go lose some weight. And for most people, I've never tried that before. Thanks for the tip.
Yeah, exactly. And we all know how easy it is for, them to try. And two, I don't know with your patients, but a lot of patients don't even want to test because they don't want to do a CPAP. They're like, I have no point in testing because I'm not going to wear that. So my approach is a little different. And I say, instead of a top down where, you get the CPAP or nothing, I want to start with the most conservative. What can you do for yourself? Now, obviously weight loss is huge. huge. And I've had a couple patients do that with extreme success, and gotten their AHI, their apnea hypopnea index score down significantly.
Could you take a moment to explain to the listeners, why does being overweight cause sleep apnea or make it worse?
So one of the things that I learned, which was extremely interesting, is how our tongue gains weight. Yeah. And when our bodies gain weight,
fat tongue. Who would?
I know. And as a dentist, what's funny is you deal with that a lot as you're practicing. You think, gosh, this person just has a big tongue, and it never really occurred to me that, wow, it's fat because maybe they're overweight. Just that didn't think of those two being connected.
So have you ever seen like a thin or a healthy weight person who's got that big tongue?
If I have, I cannot recall it off.
That's so interesting, right? Yeah. Okay, so just losing the weight, you lose you lose the spare tire, you lose a lot of the big tongue that falls back. Yeah,
correct. And the tongue, as a percentage of your overall body mass, will gain more weight per mass than the rest of your body. Wow. And it's the base, it's the back 1/3 of the tongue, the part that's really obstructing the airway where the weight is seen.
So again, just to paint a picture, so you're lying in bed, and say if you sleep on your back, your big fat tongue is falling backwards into your airway while you sleep and blocking it off. Yeah.
Plus, in addition to your big fat tongue, your neck gains weight, and as your neck gains weight, it puts weight on the airway and constricts it additionally.
Right. So it's being like the airway's being squeezed in from the outside by the fat neck, and then blocked by the fat tongue. Yes. Wow. How many people diagnosed with sleep apnea do you think have this properly explained to them? By the way.
Well, I don't think and I don't think many. Just based on, but I have a very isolated experience. So from what I've seen from the patients that I've served who have been treated elsewhere or who have been diagnosed elsewhere and refused CPAP treatment, that they know very little. Like they're in awe when we start talking about the minor things that they can do that don't cost very much money and can have a huge impact on their ability to sleep at night. You take, when we're just talking about the tongue and the neck, you take what was a garden hose able to breathe, and now you're down to, a coffee straw to breathe through. So what can we do to take off that burden, and those are the items that I really like to focus on and help patients.
Yeah. So there's weight loss, and then what else? What do you tell your patients?
So number one would be get off your back. Yeah. So sleeping on your back is, definitely would increase your chances of snoring. Now, I should qualify that there are these fancy mattresses out there now that elevate the head. So if a patient is in an elevated position, that would decrease the chance that their head is kind of falling back, and then the chin, the jaw falls back, and the tongue blocks the airway. So that would be number one. And quick and dirty tricks out there, you can do it yourself, DIY, is take 2 t-shirts, so tennis balls right at your shoulder blades. If you don't want to make something, Amazon has them. They're about $50. You can get a t-shirt on Amazon that has something sewn into the back to keep you off your back. Yeah. And that's huge, because when I do my sleep studies, my reports will show me how they're positioned. And I would say 80 to 90% of the time, the apnea and hypopnea are seen as soon as they're supine, as soon as they're on their back. If they roll over on their side, all of a sudden there's breathing that occurs, and there are no apneic events.
Got it. Let's just quickly define apnea and hypopnea.
So apnea is without oxygen. So periods of sleep when your body is not getting any oxygen, and hypopnea would be decreased oxygen level below 90%.
So with apnea, you can imagine there's complete blockage of the airway, and with hypopnea, there's reduced airflow going through.
Correct.
Yeah. Okay. And so what happens during an apneic episode is the brain essentially goes into panic mode, right? It was explained to me some time ago by a dentist with an interest in this that panic in the brain is actually what triggers the grinding.
Yes,
the bruxism.
Right, because essentially, and I describe this to patients, if they've ever had a CPR course, the very first thing you do when you have your victim is you check the airway, and you do what's called a head tilt chin lift, and you lift the chin. The reason is to get the tongue out of the airway. Well, essentially, your brain your brain is doing the same thing. And that is why you'll see that anterior wear. And to touch on this now, because I want to make sure because this is so important, it's not just about so when you're apneic or hypopneic, when you have low oxygen or no oxygen and your brain goes into panic, that's a fight or flight response that your body has. And and in that, all of those emotions that occur, you may not necessarily feel them, but that disrupted sleep can carry into the day and lead to anxious feelings because your body has, spent all night feeling anxious. And now.
So for those people who with anxiety who say, I just wake up anxious. I don't know why, it's nothing in particular. I'm just waking up anxious. This could be a part of the explanation for that they're actually,
absolutely. And it should be, in my opinion, it should be one of the first things that's ruled out. I mean, sleep, I think sleep and breathing, and going into a bigger talk about how we breathe, I think these things should absolutely be looked at before we start patients on.
That's just so fascinating to me. And the other, frankly, quite horrifying thought that just occurred to me is we know that a lot of the people who had the COVID transfection injection, the sudden adult deaths that are occurring are frequently in the early hours of the morning, and that has been explained by cardiologists like Dr. Peter McCullough as being because there's a surge of adrenaline that occurs in the early hours of the morning. And do you think it might be possible that these fight-flight responses that are triggered by apnea could actually exacerbate that?
Oh, for sure. Absolutely. Yeah. Because then you're, calling all those hormones in that your body's releasing in those, in that situation where you're being strangled for I don't know how else to say it to get people to say, essentially somebody has their hand over your mouth and nose. Do you want that every night?
It's suffocating you. Yeah, that's quite horrifying. Okay, the morning anxiety link, I must admit, is something that had never crossed my mind. But wow, I'm really going to take that on board when speaking to my anxious clients, of whom I have a lot, by the way. Yeah. All right. So airway, sleep.
And I want to say one other thing on this, because this happened to me in this past week, and I think it's important. I volunteer my time to patients who are, I'm going to say, serving time, if you will, who are cleaning up after being drug addicted. Okay. And so there's a program nearby that when they need treatment, I will see them for their treatment. I had a patient young guy, and I was talking to him about his addiction, and he's been addicted since he was 12. And when I was doing my soft tissue exam, I noticed his airway was awful. He had a collapsed arch, huge tongue, blocked airway, long uvula, all the classic signs. And I said, have you ever been diagnosed with sleep apnea? And I said, do you snore? That's what I asked. I said, do you snore? And I said, do you cohabitate to know? And he said, well, yeah, I do. And he goes, I just got diagnosed with sleep apnea and I'm wearing a CPAP now. And he's young, 20s, and not overweight. So to your question, he's not skinny, but not overweight. And I shared with him, I said, when you get out of this program, do not give up on that CPAP. I said, looking at your body's anatomy, I feel very convicted from all that I've researched that it is highly likely that your sleep apnea, your disturbed sleep as a child into your teenage years may have led to you getting addicted, looking for something.
He was self-medicating.
Yeah.
Okay. Yeah. And then when you think about the disruption to learning that occurs when a person has had a terrible night's sleep and the effect that might have on a child who is expected to pay attention in school and who, if they're sleepy or they're not taking in information because they haven't had enough sleep or enough quality sleep at the very least, they might become disruptive. And then they're told that they have ADHD and then they're medicated for that. And then there's this whole pathway that a person can go down. And all because their sleep was not assessed at a young age and problems identified. Yeah. Okay. There's so many directions I want to take this in. But
I know.
I also don't want to take over and hijack where you were going. So where were you going next with this?
So first is, get off your back. That's number one. Next would be, if you can breathe through your nose, try mouth taping. Yeah. Some of we're just lazy. We're lazy breathers and we just breathe through our mouth. And that would, when your mouth is open, it's more likely to relax in your jaw to obstruct your airway. By keeping your lips together, kind of keeps your jaw forward. And so, and I've had a lot of success with that with patients, just mouth taping.
Yep. And so describe the tape that you recommend and the positioning of the tape. A lot of people will have heard of this, but let's just make this a really clear explanation.
So for my patients without facial hair, it's some medical grade tape that's in the shape of an X. It just goes over the central portion of the lips, upper and lower. And you want to clean the skin before you put it on and make sure there's no lotions or oils that are going to make it come off. Okay. And then for my patients with facial hair, there's a tape line out there called hostage tape. I don't know if you've heard of it.
It's hilarious. Great branding anyway.
It's called, don't be hostage to a bad night's sleep.
Oh, and I see. So clever. That's really cool.
So a male patient told me about it after I had written to, I had told patients that we were going to be recommending this. And he said he'd been using the hostage tape for a long time. And essentially what I think hostage tape is for, your viewers that have facial hair, it's like the kinesthesiology tape. It's that tape that you see a lot of athletes have on their skin or on their
when they're taping a joint to stabilize it. And obviously, you've got to use something that doesn't rip off body hair when you remove it, because that would be painful. Yes. Yeah. Okay. Got it. So in a cross shape over
the lips.
Yeah. Over the lips, settling top and bottom. And I'm sure you get a lot of jokes about how the patient's spouse is going to.
Yep.
Yeah. You've heard them all, right? We won't go there. Yep. Okay. So we've got lose weight, sleep on your side, not your back, taping. What's next?
Yep. Next is the nose. So, and this can be done in conjunction with taping. I don't know if there are these strips, brand name would be Breathe Right strips that open up this area of the nose. Yep. I found them to be ineffective for me and a pain in the neck to get off in the morning. And so then I researched into something called nasal dilators. I don't know if you've heard of these, but basically
I heard of it just the other day when I was listening to a podcast with a dentist.
Was it Dr. Malik? Was it Dr. Malik?
It was indeed. It was Dr. Malik interviewing a UK dentist. Yeah.
Yes. Yep. And so I just listened to that today, and I was telling my husband as we were listening, I said, I could be best friends with this guy, because what he recommends is what I use, and it's called Mute.
Right. Okay.
And I cannot say enough amazing things. And I joke with my patients. I said, I use these, and I use them for exercise too. I can do intense workouts with them in, and I can breathe entirely through my nose through the intense workout, which normally would not be the case. So I run in them, I'll cycle in them, I'll even lift weights with them on, or in. But what I tell patients jokingly, if you have a constricted airway up here, or you can only breathe out of one nostril well and not the other, when you put it in, I say it's like you can see rainbows and puppy dogs and lollipop. It's like all of a sudden, just to feel this oxygen come in without restriction is fascinating.
Yeah. So for people who have, for instance, a deviated septum, or maybe nasal polyps or some other condition that obstructs airflow through the nose, would they still be effective? And should a person with conditions like that use that?
I cannot speak to nasal polyps, but knowing people with deviated septums who worn them successfully, I assume that would not be contraindicated.
Okay.
I think that, if you try them and they're not working, obviously don't use them. But if it brings you some relief and to be able to breathe through your nose, and they can be reused, just want to clean them really well and let them dry before putting them back in again.
That sounds like a good plan. Yeah, it's I've never been a mouth breather, but I know people who've mouth breathed from a young age, and they tell me just how difficult it is, like how much air hunger they have when they attempt to breathe through their nose, and how that gets them into a panic. So so for someone with can someone like that just start using a device like Mute and they're fine from the get-go? Do they need to kind of ease their way into it? Should they use it in the daytime before putting it in at night? What should the procedure be?
What I like about Mute specifically is it's an adjustable flare. So the part that goes up into the nares, you can adjust it. So for both comfort as well as opening. And all of this, I would tell patients, try it during the day first. If you're sitting down, reading a book at night or watching TV, playing on your phone, try taping your mouth. Just try focus on breathing through your nose. Same with the nasal dilator. If you're going to use it for sleep, You try it while awake, see how it's comfort level,
Mm-hmm.
and
Mm-hmm.
it's super, super easy to get out. I mean,
Okay.
very easy. So
Right.
if you're wearing it at sleep and it's bothering you or somehow causing you to have an opposite effect, obviously take it out immediately. But
Okay. Great. So we've got nostril, using a nasal dilator was the term that you used to increase the ease of nose breathing rather than mouth breathing. Sorry, I really want to make this complete. So the objection to mouth breathing, one that you described before, is it tends to make the lower jaw protrude.
Mm-hmm.
Yep. And then another is that we actually need to humidify air by taking it in through the nostrils. So when we take in air through the mouth, it's basically colder and drier than the air that comes in through the nose. Does that have a direct impact on dental health, by the way? Like, I know that has an impact on susceptibility to respiratory illness, but does it have a direct impact on dental health?
Absolutely, because as you're mouth breathing, your mouth gets drier and your saliva isn't there to be as effective.
We talked about that in our first talk. So your saliva is meant to be remineralizing your teeth in between eating occasions. Yeah. Okay, right. Got it. All right. So what next?
As far as this breathing is concerned for the airway?
Yes, as far as people with mild to moderate sleep apnea.
There's one other contraption that a patient he self-diagnosed, self-treated with basically like a suction cup for your tongue. And he got it off of Amazon. And you basically stick your tongue into this little suction cup and it holds it. And so that at nighttime, your lips are closed, but your tongue is just slightly protruded into this silicone cup. He swears by it. They're not cheap. When I looked them up online, they were somewhere between $70 and $90, but that's just a way to keep the tongue forward. And these are all, like I said, these are all DIY things. These are, without expense, and after these things have failed to work or patients don't get comfortable using them, then the mandibular advancement device would be my next.
So this is all kind of low cost or no cost in some cases, right. Interventions. And so you try them out first and then you'd progress to the next stage, which is things Correct. Like a mandibular advancement device. Got it. Okay.
Correct.
Yep.
And I've had a lot of success with those. Patients take to them very easily. Feedback is both from their spouse as well as from them, as far as they feel better, but their spouse is sleeping better because there's not as much noise.
Yep.
So
it's a greater marital harmony. That's a good side effect. Yes. All right.
Yes. We're not just saving teeth, we're saving marriages.
Wow, you truly are a holistic practitioner. And is there? I have read with the template with the mandibular advancement devices that they can worsen TMJ, temporomandibular joint disorder. Have you found that to be the case, or?
I have not in my practice, but I ease patients. The advancement devices, the ones that I make, are titratable. And so we start in a very neutral position and then advance forward very slowly. So I have not had failure to wear because of TMJ related issues. And the main thing in the morning, because you've been sleeping all night with your jaw forward, is to do something that encourages, you can make something that kind of positions the jaw back into the normal spot. Or I tell patients, if you're eating breakfast, you have muscle memory. Your muscles remember what to do. As long as you're exercising them in the morning, you're not going to walk around, like a bulldog with your jaw hanging forward.
Right. So the mandibular advancement device actually moves the lower jaw, the mandible, forward of what its natural position would be.
Correct. And holds it there.
Right, holds it there overnight, so say for 8
Correct.
hours, and then, but if you activate a movement like chewing, you're going to get it back in its regular position.
Correct.
Okay. But would wearing a mandibular advancement device help people who had, say, a retruded lower jaw?
It can help, pull their jaw forward enough to unblock the airway.
Okay.
A severely retruded jaw, perhaps not. I haven't treated any cases with a severely retruded jaw. But, just a simple class 2 bite, which means the jaw is mildly retruded. I've had success bringing them forward and getting the airway open at night.
Yeah, fabulous. All right. And is there anything else at that sort of stage 2, level 2 of interventions before the person resorts to a CPAP?
Sadly, that is, you have all those sort of Amazon tricks or DIY tricks, and then it's into the mandibular advancement devices, and then it goes to CPAP. If there's something intermediary between CPAP and, the mandibular advancement device and the CPAP, I'm not familiar with what it is.
And are you? I think a while ago I sent you a link to Mike Mew's YouTube channel.
Yes. Yes.
Yeah. So, what do you think about mewing? I don't spend a lot of time in YouTube land. It's a really weird place, but I see that there's a lot of people who've taken to mewing and are posting their before and afters. What do you think?
Well, I think it's all very interesting, and I want to learn more about that, and even just how I believe he wants to intercept with children to get them earlier, and so that you can possibly avoid orthodontics later as teenagers by encouraging proper mouth position. So that's something I still have a lot to learn on.
Yeah. So, mewing, sorry, for my audience who haven't stumbled across this particular, domain in YouTube land, is a set of practices that's essentially intended to develop the musculature, or this is my understanding of it, the musculature of the particularly the lower face, through a lot of chewing based exercises. Yep. Predominantly, there's no doubt more to it than that, but that's what I've seen so far. And yeah, I've heard a couple of interviews with Mike Mew on various podcasts, and he does emphasize intervening at an early age. Most of the before and after videos that I've seen, though, are adults. They're people at least in their 20s and beyond. And when they do these before and afters, and they post photos of their face, both, sort of face on and in profile, and you can really see like the position, the indentations beside their nose actually change, and the position of the lower jaw will often come forward, and the jaw actually looks more developed. So although Mike Mew wants to intervene at that childhood stage, it looks at least as though some adults at least can get some, very visibly noticeable benefits from it. So anyway, that's most interesting.
Well, one more thing on him, he must be on target on some level because he's being investigated. You know when somebody's doing something right when they're being investigated.
Yeah. If you're copying flack, you're over the target, right? It does seem that way. And it's so. I want to talk about orthodontia. You've mentioned it there briefly in terms of Mike Mew wanting to intervene in childhood so that kids don't end up having orthodontia. What's the problem with orthodontia? What's the problem with getting braces?
Well, so at a time, and I assume we're about the same age, our age bracket and a little bit older, the orthodontists were really in the habit of extracting teeth to make room instead of expanding arches to create an ideal shape, and then, as we were saying in the last podcast, room for the tongue. And I would say, at least where I am, it is not common practice nowadays to pull out the first premolars, which was very common. The first premolars would be removed, somewhere around the age of 10 to 12 to create room where there was crowding versus just taking the time to expand the arches a little bit. And then I don't specifically have an issue with orthodontics. When teeth are crowded and misshaped, or the arches are collapsed, absolutely intervene. If you can open up the arch, create more room for the tongue, create a more ideal bite, I am all for doing that.
So specifically the extractive element of orthodontics that you have an issue with. And again, this is because it actually makes the dental arch smaller and therefore impedes the airway, essentially.
Correct.
Okay, good. And is there anything inherently damaging about having braces on the teeth, though, in terms of, I don't know, anything like restriction of the natural movement of the teeth within the jaw?
Well, I would say the number one issue, especially with when you're mostly doing braces, is the teenager, young adult who already has a poor diet and poor oral hygiene. You're just exacerbating a situation. I mean, what we see when patients come in as far as their tissue health, as far as the biological part of it and the, keep moving teeth and all of that, I have not read anything that would make me feel hesitant to put my child in braces should they need them for that reason. But specifically oral hygiene and then the decay that you might see afterwards after they're removed as a result of, poor care during the treatment time.
And so you mentioned in terms of diet, so there are certain things that people with braces find very difficult to chew. And then it's also difficult for them to clean around the braces. So
Right.
And what is chewing? It's an essential human activity that ensures that you have well-developed musculature of the lower jaw. And something I find really, really fascinating, and I think Mike Mew has, I'm pretty sure I heard this from Mike Mew, is that if you look at exhumed skeletons from people who were buried a couple of centuries ago, the symmetry between the upper part of the face and the lower part of the face, well, basically there is symmetry. That is the lower part of the face is as well developed as the upper part. And now we have all these people whose lower part of their faces is basically really underdeveloped because people eat mush.
That's right.
They start eating mush from infancy, and then they continue to eat mush their entire lives, and they just don't chew stuff. So that's pretty interesting. Yeah. Okay. So is there anything else that you wanted to say about orthodontics or about the airway?
Well, so I would say it starts at birth and encouraging breastfeeding.
I'm glad you went there. Yeah. Okay.
Yeah. So obviously nursing forces that the baby has to work harder, and the tongue is working and the jaw is working, and to create that suction and that seal, and it encourages proper jaw growth. Obviously, the nutrients and all that baby gets from the breast milk too, and so encouraging that as long as you can with your child, and
that specific muscular activity of forcing the tongue against the palate, right, to extract milk. Yeah. Okay, so. Yeah, we should not make it easy. Dummies. What do you think about giving children? Do you call them dummies? I think you call them pacifiers, don't you? We use the English usage of dummies, which is.
Well, I was listening to that podcast today, and he's an English guy, and he said gummies. I'm like, what are gummies? So now I know they're pacifiers.
Oh, dummy. Sorry. So like a dummy. D for dog. Dummy. Yeah, that's what they're called here. Dummies. Yes.
Never. Okay.
Yeah. Isn't that terrible?
That's terrible.
So, probably so appropriate.
So thumb sucking and passies or dummies would be a no-no. And I'm so grateful that I didn't know this when I was rearing my children. I breastfed, but both of my children found their thumbs, and I was so grateful, because they were good sleepers and we didn't have any deleterious harm. But now what I know now, I'm like, I would have had their thumb right out of their mouth.
Yeah, painting that awful tasting stuff on the thumb. And all that sort of thing. Yeah. Okay, got it. Okay, so breastfeeding is really important, and then rather than weaning your child, so solids should not be all mushy, right? We actually need to give children something to chew on. It's really interesting. I had a Lebanese client years ago, and in Lebanon, the custom is to give quite young children whole nuts from quite a young age, because they figure, well, you got to learn to chew these suckers sometime, and if you choke on it, I guess you'll figure out how to get that thing out of your airway pretty damn fast, and then next time you won't be so lazy. So they have a kind of tough love approach to parenting, apparently. Whereas there's all this concern about, you can't give children this, that, and the other because it might get stuck in their airway, and like my Lebanese client was like, they're going to get it stuck in their airway sometime or other. They'll figure it out, like learn first aid, learn how to do the chest thrust on a young child. Anyway, So they're not in the habit, in many cultures at least, of giving kids all food that's all kind of mushed up. Instead, they actually give them crunchy, chewy food to crunch and chew on, which is super important. Any other tips for parents of babies or young children for how they can just encourage better?
So I recommend
jaw and airway development.
Okay. Oh, jaw and airway. No, that would be all for jaw and airway. That I have.
Sorry, so you were about to say something else about babies.
I would just say to my parents with young children or babies, to get them used to having their teeth brushed, to start even when their gums, just put a little baby toothbrush in there, to start getting them used to the fact that you're doing it, to help encourage when they're a little bit older and maybe wanting to resist that this is just how we do it at nighttime, or whenever you're doing the toothbrushing habits. You don't want to use a brush on a baby. You can use a washcloth. That too will work, just getting in there to get the child used to that. And in our country, I don't know about in your country, but they recommend a child see a pediatric dentist at the age of 1. Is that how it is for you guys too?
I actually have no idea because I didn't really follow the conventional advice on raising my children. My kids were both planned home births, and they weaned themselves, one at just over 3 and the other at 3.5. So I kind of didn't play, and they weren't given the childhood vaccine, so I didn't really play by the conventional rules. I have no idea what's recommended because we didn't see a doctor.
I love it. Well, I tell my parents, I say, I think 1's a little early. I think that just instills a lot of fear in the child. As long as you don't put the baby to bed with a bottle, your child's going to be fine. And I usually recommend starting around the age of 3, but to see a dentist as far as checking for cavities and
gotcha. That actually segues nicely into a question that I actually wanted to ask you last time. But anyway, here we go. So the advice that is given to adults at least is to have a dental checkup, say every 6 to 12 months, depending on your oral health. What do you think of that advice? Should people have regular checkups even if their dental health is good? Are they likely to experience more harm than benefit from that, depending on what dentist they see? Like, what would be your general take on seeing a dentist regularly?
So I like to tailor it to the patient. And sadly, there are patients that they can't go 2 months without seeing a dentist. I don't know what is happening at home. They'll tell me they brush 7 times a day and floss at least 3, and you're looking there like, I don't know if you've ever seen a toothbrush. So I don't know what metabolically is happening.
So they're basically little plaque factories in there.
It's horrible. And so when you say 6 months to a year, in this country, I don't ever hear that. It's usually 3, 4, or 6 month interval cleanings is what most patients are on. Now, I will say my patients who have clean diets, healthy eaters, clean living, absolutely, they can go a year or more. And, I have some patients, I won't see them but every 5 years, and they'll come in. I'm like, it seems like you were just here yesterday. It looks like you were just here yesterday.
So their teeth are clean. They don't have a plaque buildup.
Correct. Yeah. So gotcha. I like to tailor it to the patient, and same with x-rays. I just tailor it. If you haven't had a lot of caries activity, then having the x-rays spaced out a lot longer than what we typically recommend, I am fully on board with.
I remember there was something that you said the first time that we spoke that really, really stood out to me. And it's not that it's new, because I've heard this before in relation to really any I suppose you'd say pathology testing, and that is the interpretation of x-rays varies from one practitioner to the next. And that's definitely true. I mean, look, when people get a cancer diagnosis and they're told that it's grade 2, grade 3, whatever, most of them don't understand that that's basically the judgment of the person who's looking at the cancerous cells through a microscope. And if you show that same person the same slide 3 days later, they might actually grade it differently. Or if you take that slide and show it to another pathologist, they might grade it differently. In fact, they often, or it's probably fair to say usually do. And so if you are seeing a practitioner who's a bit intervention happy, their interpretation of your x-ray might cause them to write a treatment plan for you that's a bit more aggressive than somebody else.
The one thing that's a little different in dentistry versus medicine is you have the comparison of what else is happening in the patient's mouth, that their history is right there. So my specific approach with patients would be, I may see something on an x-ray that looks like the start of a cavity. We would call it an incipient lesion. In their history, they've had no fillings or very few fillings. I'd say, you know what, we're just going to keep our eye on this. This may be an arrested area that is not active and has, all activity has halted. But if you have a patient who has a bad history of very deep cavities with root canals, I would be far less conservative in that patient to wait to see what the result was. So if, for your listeners who've had a really good, you going? Can I get a quick kiss?
Oh, what a cutie.
That's my little boy. So if your listeners have had very few cavities in the past and have good oral health, spacing out the x-rays a couple of years, I think is completely safe. And if something is found, I think it would be worthy of monitoring or keeping an eye on before aggressively approaching it. And then just the opposite, if you have a bad history of cavities, root canals, areas where you've had
I want to come back to root canals in a sec, because we had a lot of questions around that.
Yeah.
But, so is it, there is a lot of talk again in online spaces about various practices that can reverse cavities when they're in an early stage. One of the things that's most heavily promoted is oil pulling. And I have a client who's a dentist who basically says, well, that's bollocks. But what are your thoughts? Are there any practices, are there any substances that can actually reverse cavities when they're at an early stage?
Well, I guess you'd have to define early so this client of yours does not like oil pulling?
Correct.
Oh, okay. Well, I love it. I think it's fantastic. And I plan to write about it. So coming up. But so you have the enamel, which is the outer layer of the tooth. And that often when you see something active there on the x-ray, because our radiographs are not as specific as we'd like them to be, there's often more going on into the dentin than what you can see. So when you're asking if you can reverse a cavity, yes, you can in the enamel. The enamel has the ability to heal itself when given the proper environment. The way I describe it to patients is like bone. Your bones are constantly breaking down and building back up. Same thing's happening to your teeth. There's constant breakdown and building back up.
So this is the remineralizing from saliva.
Correct, remineralizing. Yeah. Okay. As far as a cavity getting into the dentin, which is the next layer of tooth, to me that I describe that as a cancer now. It's a cancer growing in the tooth. Can it reverse itself? If it can, I have not read the research that says that there's treatment out there that can reverse it at that stage. I've heard a little bit about ozone, and I've watched some videos on the benefits of ozone and being able to halt that process. I just haven't practiced it, so I don't know.
You can't comment on that at this stage. Yeah, that's fair enough. One of the issues that I have read about with oil pulling is that it may actually leave a coating or a film on the teeth that prevents remineralization.
Well, that's interesting. I was just reading something on Friday as I was working on what I was going to write about this and how that coating could potentially discourage the bacteria from recongregating the biofilm.
Interesting. So you've got two opposing forces at work, haven't you? Yeah, like you want to keep the bacteria away from that site, but you also want to allow the minerals from the saliva to reach it.
Yeah, and so when I oil pull, I do it in the morning, and I assume your listeners know what it is, but it's using typically coconut oil, about anywhere I've read from a teaspoon to a tablespoon. I just tell patients whatever's comfortable, as far as the quantity in your mouth. And it's a solid at room temperature, it liquefies. And then with pulling, you want to swish with it for what is a lot longer than what you typically would do with mouthwash. And ideally somewhere between 15 to 20 minutes, which sounds absolutely crazy if you've never done it. But once you've tried it, I don't know if you do it at all, it is super easy. And one of the benefits of oil pulling is it forces you to breathe through your nose the whole time because you have oil.
So you're kind of forcefully swishing it around your mouth. Again, I've looked at some studies where there was a placebo control with this, which was basically swishing with water, and it basically did the same thing. And so it may just be that swishing something around your mouth very vigorously for an extended period of time disrupts or moves bacteria out of the spaces between the teeth and stops them from doing their dirty work of making these acids that erode the enamel. That's my understanding of it as a non-dentist.
Well, no, and that's excellent because that's exactly what I read. But even before I had read that, I tell patients when they ask me what's the best mouthwash, I said, I don't even care if you just use water. Just get in there and swish because you're cleaning. So this is goofy, but I tell patients, I liken cleaning your teeth to washing your car. And when you wash a car, don't you hose it down first, kind of get everything loosened up, and then you get in there with your floss or your brush to kind of get the final grip, and then you always come back. You always hose it off at the end. So that's where you're rinsing at the end, is there to kind of clean up what
Yeah.
you've done.
Interesting. Okay. Yes. God, I'm trying not to jump all over the place, but
I know, but you gotta get to the
that kind of
topics.
leads into, so your recommendations for daily dental care would be, are you a yes floss or a no floss? Are you a water pick or a dental floss? Like, where do you stand on the great flossing?
Okay, so I tell
question?
my patients, if I was stuck on an island somewhere and I could only have one thing to clean my teeth, it would be the water pick. So the island would have to have electricity, of course.
Solar panels, maybe.
Yeah. So, but to me, the water pick is the epitome of what you can clean your teeth with.
Okay.
So, unfortunately,
and the advantages of that over floss would be what? Gentleness, I suppose, for one thing.
So a lot of people don't floss properly, and they just cut up their gum tissue. And flossing doesn't remove the plaque; it just moves it around. So you're kind of just, pushing it around. It's not actually sticking to your floss. Some of it may, but there's still a lot that stays in there. So with the water pick, not only are you disturbing the plaque, you're also rinsing it out, or flushing it out. And there are nooks and crannies on the tooth structure that when you're taking the floss over, if the tooth has some type of fluting to it, you're only getting the flat surface. Whereas the water pick, the water can go in and clean out, what I would call nooks and crannies in a way that the floss can't.
Gotcha. But, okay. So water pick before brushing or after?
So my perfect recipe for patients would be, if they did what I told them to do, would be to rinse first, whether it's oil pulling, and then you would attempt flossing if you're going to floss, and brush, and then you would water pick at the end, like your hose coming in and cleaning everything.
Oh, wow. Okay. All right. I'm with you. So the water pick would be the final rinse of the car. Yeah.
Yes. Yeah.
Gotcha.
Yeah.
And twice daily, once daily, when?
So obviously, well, in our country, it's recommended twice daily. And when I was listening to the podcast today, it was funny where the dentist was just sort of admitting to the fact, well, we tell them twice a day because, it's just because if we say once a day, they might not do it at all.
So if you say twice a day, then they might hit once.
Right.
Yeah.
So,
yeah.
This is where our conversation, I know we can go in so many different ways, but, so my husband and I do fasting. And the intermittent fasting. So we're only eating in a small window of time. So for us, brushing twice a day, although I still do it, is really not necessary because I haven't eaten for 18 hours. What's the purpose of brushing other than it kind of feels good?
Yeah.
But I think ideally still for most Americans, twice a day is ideal. But if you're somebody who's only eating one meal a day, you could just do it after that meal.
Gotcha. Okay. So really it's just about cleaning the residue of the food that you've eaten. So if you haven't eaten, there isn't really a need to brush. Yeah. Except for like mouth freshness, say. And correct. And to which I would say, if you've got a disgusting taste in your mouth when you wake up, that's a bit of an indicator of your general health. You might want to take a closer look at just why it is that you wake up with that awful taste. One of which would be mouth breathing, of course. Mouth breathing overnight, which tends to give people bad breath. But the other is that the tongue being essentially, it's a mucous membrane, so it is used as like an overflow system for elimination of body waste, and so that kind of coating on the tongue.
Big fan of tongue scraping. I didn't cover that as part of the overall thing.
Yes.
Big fan.
Work that into the oral. So tongue scraping before brushing.
I do it before I brush. And I don't want to, I personally do not like the idea of brushing your tongue because you're just kind of brushing the bacteria. And I like to scrape my tongue using, they have plastic scrapers out there, which I don't like. I prefer a metal scraper. Yep. And I heard today they have copper scrapers. I'm going to look into them.
Yep. Which I imagine would have some antibacterial effects as well, copper?
Yeah. Yep.
Okay. That's just made me think of the oral microbiome too. So, there's so many questions I want to ask. Do you want to touch briefly on the oral microbiome? And is that something that is now being talked about in dentistry, in the training of dentists?
I'm sure on some level it is. It wasn't a big part of how I was educated, and I'm seeing more and more out there. In fact, I just looked up 3 articles that I want to read on this very topic, specifically the bacteria in our mouth that produce nitric oxide, which gets back, I don't want to get too far, but when nasal breathing is so important because your body produces nitric oxide, which is a vasodilator. But there are bacteria in the oral cavity that also produce nitric oxide. And there may be some implication in patients who have periodontal disease or unhealthy, sort of an overgrowth of the bad bacteria versus the good bacteria, that you'll see an increased risk of cardiovascular disease. I know now there's a link with Alzheimer's or dementia, and we know preterm birth weight. So all these factors, and this is certainly something I want to research more.
I have read that the oral bacteria that are implicated in periodontal disease are frequently found in thrombi, in clots that form when people have a heart attack or a stroke. So that's extraordinary. We're talking about bacteria from the mouth that wiggle their way into the bloodstream, and then essentially they prompt the formation of a clot, because you're not meant to have bacteria floating around your bloodstream, right? And so, and then beyond that, so nitric oxide is a vasodilator. It opens up blood vessels, and so now you've got another risk factor from poor oral health. If you lack the bacteria in your oral microbiome that can make that nitric oxide, then you're not going to have that healthy responsive vasodilation. So if you do get a clot that forms, you don't have the you don't have the nitric oxide to counteract that clot. Oh, and the other thing is that nitric oxide stops white blood cells and oxidized cholesterol from adhering to the artery wall and forming a plaque. So it's pretty wondrous stuff. And
isn't it also antibacterial, antiviral? I believe it also has.
It pretty much does the works. So quite early on in the whole COVID episode, I watched a fascinating video from a lifestyle medicine doctor in Hawaii, and she was talking about the value of humming at a particular frequency for generating more nitric oxide. I can't remember what frequency it was, how many hertz, but I found an online tone generator. And it actually like you just plug in how many hertz you want, and it gives you the exact tone, and so you can match your humming. It was really interesting because it's basically the same hertz as like it was bang on that kind of. Have you ever been to a meditation group where people are coming and saying and whatever? It was exactly that tone. I'm like, man, these ancient people, they were onto something, weren't they?
I know.
Stuff. So you've got humming. Oh, I should have turned that off before. You've got so nitric oxide generation, which has this whole suite of effects, both within the nasal and oral cavity, and then into the rest of the body, all of which is impacted on by your oral health. And at least at the time that you were training as a dentist, I'm gathering there wasn't really an emphasis on this. And this, of course, as I know this is one of your frustrations, right? That the way that medicine and these paramedical fields are all divvied up, they're all siloed off. And so you're a dentist, you do teeth and like gum health. That's it. That's your little niche over here. And then, the patient that you're seeing is seeing one specialist for this and another specialist for that, another specialist for whatever. And there's no one kind of overseeing that entire human being.
Well, two things. So I joke with my patients. I'll say, you know what? It's funny. The mouth is actually connected to the rest of the body.
Wouldn't have thunk it. What a crazy idea.
But then I'll joke with them and say, I'm kind of like your quarterback. And I know nothing about football, so my husband's sitting right here. I might have this all wrong. Like football, not your soccer. But, I'll say, think of me like your quarterback, trying to pull all these different specialties together. That's what I would like to see my role evolve into in this next half of my career, as I learn more about how the systemic health and the oral health are actually connected to one another, to help these patients put these puzzle pieces together, because so many patients are left to doing it on their own, and either they're not interested or they don't have the time, or I'm sure it's overwhelming too. But to have somebody kind of in their camp looking, kind of putting these puzzle pieces together. And that is where you have been integral for me. You have been such a godsend, sharing your posts with my patients on certain topics that I want them to learn about, but I don't always have the
Oh,
time to
that
read.
warms the cockles of my heart. Yeah, as you know yourself, when you start a Substack and there you are, tapping away on your keyboard, having no idea whether anyone's actually reading it, whether they're making use of it or whether it's just like a total waste of time. So
No,
really,
it is not. It is
yeah,
huge what you're doing. Huge.
it's really exciting too to think that here am I in this in this little Queensland country town. And your patients in North Carolina are actually reading some of my ramblings. It's really cool. So thank you, Substack. It's awesome. Okay, let me see. Root canals. Let's talk about root canals. There were so many questions that my readers had about root canals.
Well,
Sorry, I'm just sorry to interrupt. I'm just going to preface this by saying that there is a quite prominent school of thought out there in what I'll broadly call holistic dentistry, that root canals are terrible, that they should never be done, that they create basically an ongoing source of inflammation within the mouth, and that thereby having root canals is linked to an increased risk of cancer and cardiovascular disease and a host of other really nasty things that people never want to get. And then there's another camp that says all that is complete rot and it's just scare stories. Do you have a position?
So I think I fall in the middle, and I don't want to disappoint your listeners and viewers. And I didn't respond to anybody because I thought this topic was a little heavy just to write quickly in a reply on Substack. But I lie in the middle, and the reason is I agree with the holistic side that yes, a root canal treated tooth is absolutely the source of a chronic, can be the source of a chronic infection. And if so, and especially with the more diagnostic imaging that we have available now versus when I was in dental school training, 3D imaging can do a lot better at highlighting a tooth that may have chronic infection around a root canal, even if it's asymptomatic. I mean, that's the thing that's so bizarre to us as dentists. And this goes back even when I was working for my dad as a dental assistant. He would extract a tooth and or something would come up and he'd be like, this is a root canal that's been in there forever. And look at the amount of infection that came out after the extraction. It wasn't something that I can't recall the reason the teeth were being extracted at the time, but so my dad was of the belief even back in the 80s and 90s that these, he goes, I think we're going to someday learn that there's a lot of these root canals out there that are chronically infected, but that's not. But
the patient didn't have that tooth extracted because he or she was in pain or whatever.
Yeah, and I brought that up without recalling the full story. So
I know it was a long time ago.
I'm trying to recall why my dad had that notion, but. That aside, I have patients who have no symptoms, no concerns whatsoever, and something shows up on the X-ray, pathology on the X-ray, and it's just interesting. And then you'll have a patient where the root canal looks like it's perfectly done, and they'll say, I can just always tell. I can always tell that this tooth isn't quite right, or I always get sinus infections on this side. Is it related to the root canal? So I had a patient, in the last 4 years who she actually had a root canal retreated, and it cleared up sinus issues that she'd been having for a decade or more.
Just fascinating. When you say retreated, you mean that root canal was what, kind of like bored out and then reflushed? Because sorry, the reason I say this is because a holistic dentist that I saw when I still lived in Sydney said, look, the problem with root canals is just how well the tiny, I could have my terminology wrong, dentin channels.
Well, so you have the root canal space, the main canal that the nerve and blood supply flows through, that's filled. And so when you look at it on an X-ray, when you see that white line going up the root where it's obturated, that's the main canal. But as I explained to patients, you have the tributaries of that.
Gotcha. So you were saying that the problem is that those tributaries are not properly flushed. They're not properly disinfected when the root canal is
that's true. Yeah. We don't have a system for that. And, so where I get hung up, why I kind of hover in the middle on this topic is that I've seen a lot of teeth saved by a root canal that have gone on to be very healthy for the patient. The patient's, 85 years old with no other health conditions. And so they were able to save a tooth. So my response to somebody asking me this question would be, if it were me, I would absolutely have the root canal first. I would try it, see how it went. If you started noticing other things that might be related to chronic infection, then absolutely consider the root canal. But your other options, having the tooth out, we've already talked about this, starts to collapse the arch. Yeah. Your means to replacement are an implant, which I could spend a whole nother interview talking about my frustration with implants. And then you have a dental bridge, which is a cemented units of crowns that splint that fake, what I call a fake tooth or Pontic. But sometimes you're unnecessarily grinding down virgin teeth to then support. So, in my sort of triage of that is absolutely try the root canal first. Yep. If you're dead set against a root canal, if you have listeners that are dead set against a root canal, which I respect, then I think just where I am right now, I probably would err on the side of the bridge before the implant.
Interesting. Yes.
Because of the failure that I'm seeing in the implants. And the implants, in my opinion, in my experience, my implant failures seem to be more in areas where a tooth was removed due to infection. The implant fails to infection. Sometimes teeth are removed because they break or they split or they've been missing forever. Who knows how long they've been missing and why they were originally lost and an implant goes in. Those do not seem to be an issue. I can't think of one situation where I've lost an implant to a site that wasn't previously infected. But if the site was previously infected, the implant seems to have a higher rate of failure.
And when you say infected, this would be decay that went very, very deep. Into
the nerve. So your readers who have put in the questions about whether or not they should get a root canal or they have a tooth that's been deemed to need a root canal, it must mean that it's infected for some, it's infected, whether, it's due to cavity or past trauma, because there's different reasons why teeth become infected. So in that situation, if they decide to have the tooth extracted and have an implant placed, my experience has been that I see a higher rate of those implants failing to infection. Is it because we don't wait long enough for the body to heal that area that was infected before we put the implant?
Interesting. And so if a person was in that situation, they should do, and they were going to proceed with an implant for whatever reason, they should take every possible means to clear up that infection. And I presume that would mean, what would that mean? Is that an area where, for example, ozone might be?
Oh, yeah, I think that could certainly help. I also think time. I think time is huge too. Okay. But my secondary issue with implants for those people considering it is hygienically, they are so much more challenging to clean around in the posterior. And it's
okay. So an implant in the back teeth is more problematic in that way than an implant in the front teeth.
And the reason is it's like a lollipop on a skinny stick. You got this big old molar that takes up all this room, and the roots of that molar were very broad and wide to support it. But your implant is this teeny tiny little stick going in the middle.
I'm with you. Okay.
And so then when we restore it, there's just food just naturally collects in that skinny little area under the implant. And so if the implant itself is not infected, I see a lot of chronic infection around the base of implants because people don't clean around them properly. So
gotcha. Oh, it's complicated. There's a question too about the materials used for implants, and sorry, I'm just blanking on the metal option.
Titanium and zirconium are the two. And so I actually, when I saw that question come up in the when you sent that out, I actually called around to a couple people because I've never used zirconium. I've only had titanium implants. And the biggest, and I talked to 2 oral surgeons about it, and then I also talked to the gentleman who runs the dental lab where I send all my lab work about, why don't we do more zirconium implants? And the main reason being, the main thing I heard was, why are we fixing something that wasn't broken, as far as the titanium working so well with osseointegration? And then the other from one of the oral surgeons was, she wasn't pleased with the amount of research on zirconium as far as being a replacement for titanium. And then
in terms of compatibility with...
and then the lab guy brought up, well, if they're trying to get away from the metal, well, the abutment, which is the part that goes into the implant, is always titanium. Anyway, that I don't have a lot for your listeners or readers on that topic.
Okay. It's basically further research needs to be done.
But there may be others that know a lot more on that, but I don't have a lot of information to share.
Okay, terrific. Look, there were some other questions that were submitted by readers, which I don't know whether you've had a chance to look through them, or whether we might actually kind of cover them later on.
I'm happy to.
Because we've been talking for longer than I said I would tie you up, and so I want to wrap up today with I suppose two questions that are that are quite interrelated, I guess. So let me frame this. We touched on this before. And it's in relation to the training of dentists. If you became, ruler of the world for a day, and you could actually change the way that dentists are trained, the way that dental schools teach students how to be dentists, what would you do?
One of the things I jokingly tell my patients is, my job is to make it so that you don't need me. Right, is to create a situation that you're healthy enough that, essentially renders me useless. But I don't want to be useless, for sure.
It would take quite some time before you achieve that goal.
I really wish that we would have a much more holistic approach. See us, like I was telling you, as the quarterback. Because I don't know about your country, but in this country, I have patients that I've been caring for now for 24 years. I have seen them through all of their life's challenge, not all of their life's challenges, but I've seen and heard about, what they've been through. And patients will come in and talk to me about things which I feel extremely honored and grateful that they entrust me with certain information, that it has nothing to do with their teeth. But it's all, obviously it's all connected on some level, because it's their health and their being. But so that we could be better prepared to help patients navigate those different challenges where everybody's so subspecialized and they're getting information from one doctor and another doctor and help them kind of pull all this health together, because our health is kind of starting here. If we can't breathe, we can't live. If we can't eat and drink water, we can't live. So it's all kind of starting here. So that would be, if I were ruler of the world for the day, that's what I would do with dentistry. I have lots of other things I would do too.
Yeah. Okay. And related question, you expressed before some frustration that often you will speak to patients about things that they could do at home, things that they could do to care for their own dental health and oral health and that of their children too, I guess. And you often get resistance to that. This is a very broad question. What do you have any thoughts about what has led, let's just say, Western populations to the position where we're in now, where people abdicate responsibility for all manner of things? They abdicate responsibility for the education of their children to schools, which seem to be miseducating children. They abdicate responsibility for preparing food to some nefarious conglomerate of junk food manufacturers. They abdicate responsibility of the care of their teeth to you, the dentist, rather than saying, hey, Dr. Funk, what can I do at home to take care of my teeth? They abdicate responsibility for just about everything. I know you do have age pensions in the US. We have overall a far more I could use the term generous, but I'm not sure that that's the correct word for our welfare system in this country. I don't know that it is generosity to turn people into dependents of the state.
No.
Okay,
That's
so
punishment.
yeah, so anyway, sorry again, that was a very broad question. What do you think is going on in that sense? We have a bunch of people who are, let's be honest here, and I'm not going to use politically correct language. We have a bunch of people who are fat and lazy and really
Yeah.
sick
Yeah.
and not taking financial responsibility or
Yeah.
responsibility for their health. What the heck is going on? How do we get here? How do we get ourselves out of it?
If I could answer that question, you and I would not be sitting here right now.
Yeah, that's no doubt true.
But as you were talking, I mean, you're driving a knife into all the things that just frustrate me. I mean, you're hitting the nail on the head with every single comment. Back 10, 12 years ago, I toyed with the idea of politics, and my whole platform would be personal responsibility. If we could all just take personal responsibility, we would have so many less issues. And then I think of Dr. Mercola. I'm sure you know Dr. Mercola from Florida.
Yep.
Take control of your health.
Yeah.
There's nobody else in this world that's going to care more about your health than you. So, and I wish I could answer that question, because it frustrates me to no end to watch. Just give me a pill. Just give me a pill to fix it. It's lazy. Well, I think what you just said too, and again, not to get too political, but you almost, by giving people everything they want, you almost enslave them in some way, where they become so dependent that I think it is a form of slow torture, that they just are unfamiliar with what's actually happening. And there's nothing better than to empower somebody, like the name of your empower total health. I mean, that's such a great word. Don't you want to just
my husband actually came up with that as my business name.
I love it.
He's pretty clever with these things.
Yeah. But there's nothing better than empowering somebody to do something on their own, and by doing so, you lift yourself up too. If you empower somebody else to take care of themselves, that can help lift you up too.
Yeah. That is a beautiful note to end on. So for all those people who are saying, "Oh, but it's so hard. I don't have time to do all of this stuff." Like, well, what do you want to spend your time doing then? You want to spend your time in a doctor's office, or how about in a cancer ward? Does that sound like fun?
Right.
Yeah.
And as you well know, once you start doing it, once you start cleaning up how you eat and exercising and sleeping well, I mean, it's amazing how good you feel.
100%. The rewards are so stunning, and it saddens me no end that more people aren't reaping these rewards because they're put off by the initial barrier to entry, right? They perceive that first barrier and they say, well, gee, that's too hard. That would take some effort. Yeah. Do you know what? If you just knuckle down and put in that effort, whether it's taking care of your oral health, whether it's, taking the time to prepare healthy food, whether it's taking the time to move your body every day, if you just put the effort in for a relatively short period of time, you would feel so good. You would get that time back because you'd be more productive, you'd be more energetic, you would just enjoy life so much more. And I wish, there might be one use of virtual reality that I would go in for, and that would be, let people who are currently living in an obese, unhealthy body, let them live in the body of someone who's actually fit and well and strong and takes care of themselves for a day. Just let them really experience how different their life would be, and maybe that would motivate themselves to put down the Coke and the McDonald's and go make a salad and then take their dog for a walk,
Yeah, and grow a garden.
Oh yes, we're on 5 acres now, and it's so magical. It's so magical to go out as I did yesterday and pick mulberries off the tree and eat them for breakfast. To pick mangoes and salad greens and whatever. It's just the best. So, okay, could I get you back on?
I would love that.
All right, excellent. That's great. So we'll take up a time to speak again. Any last words for my listeners?
as far as we're kind of touching on what we touched on last time with your dentist, this should be a open line communication, and you should never feel threatened or forced into a treatment that you do not feel comfortable with. And then I would find another dentist that listens to you and respects your desires. And ultimately, the healthier you eat, the less you need me.
Amen to that. All right. Thank you so much once again, Jessica. It has been incredibly enjoyable for me to get to know you through these conversations, and I'm looking forward to speaking to you again. So for my readers, my viewers, the post where I initially solicited questions for me to ask Jessica, that's still open. You can still leave comments on that, or just leave comments on the post that I'll be putting this video on. And I look forward to speaking to you again really soon.
Thanks, Robin.